We have another amazing session, and we have with us Dr. Amanda Olsen. Dr. Amanda Olsen earned her Bachelor of Science degree from Pacific University and a doctorate degree in physical therapy from Regis University, graduated as a member of the Jesuit National Honor Society. She holds a certification of achievement in pelvic floor physical therapy, which is super cool, from the American Physical Therapy Association, and the pelvic floor practitioner certification through the Herman and Wallace Pelvic Institute. She's also a certified Stott Pilates instructor and RRCA certified running coach. She's the president and chief clinical officer of Intimate Rose, where she develops pelvic health products and education. She's passionate about empowering women and men with pelvic health issues, including pelvic pain, incontinence, pregnancy, and postpartum issues. Dr. Olsen teaches internationally on various pelvic health topics, including pelvic floor dysfunction in runners, and she's written newspaper and magazine articles on pelvic floor dysfunction and running, and has also authored the book, Restoring the Pelvic Floor for Women. So I'd like to welcome Dr. Amanda Olsen.
Thank you so much for having me.
But you have a lot of things that you do. So that is so incredibly, actually we are going to get to talk about pelvic pain, but I kind of want to go into a little side thing because I'm interested in the running. That is something, I am not a runner. And I know I have a lot of female friends that are runners. I think I've always used the excuse like, oh, I have bad knees, but running can affect so much more than just the knees. What kind of problems can you develop as a runner?
There's a lot of different types of running related injuries, and the statistics show that throughout a runner's lifespan, roughly 97% of runners will experience some injury in their lifetime, most commonly at the knee and the foot, and then usually in the low back. Generally, they're a product of training errors or from volume related issues or running mechanics. So it's generally one of those things that as long as they get appropriate rehabilitation and they get appropriate running gait retraining, they are able to grow out of those injuries, but sometimes they can be cyclical if they are not addressing the root driver.
Do you ever see pelvic problems with runners too?
Yes, I've published on the topic, and I actually teach a whole 2-day class just to practitioners on pelvic floor dysfunction in runners. We see it in both men and women runners that they may experience some pelvic pain that may drive issues in their running. And then certainly for women, especially with pregnancy and postpartum or different changes throughout the lifespan hormonally, we can see issues of urinary incontinence that limits their running, or pelvic organ prolapse that they experience from a pelvic floor gynecological related issue that then impacts their ability to return to run or continue running. And so it requires a special amount of rehabilitation and care to gently and progressively rehabilitate both the pelvic floor and the changes to their running gait in service of getting them back out and doing the thing that they love.
This is so fascinating because when I think of pelvic floor, I often think of cyclists. And
yes.
And around January, when everybody's gotten their Pelotons, and then February and March, everyone's coming in with pudendal nerve irritation and pelvic floor issues.
It is a thing. Absolutely. That compression at the groin can be devastating to men and women. And you are absolutely right. It is when they get brand on there and they're not fitted properly for their seat, or they're not using good mechanics. It's really hard on them.
Oh my goodness. And so I love your specialty. I think that pelvic physical therapy is like gold, because when I first trained, there was no pelvic physical therapist around where I was located. And you're so incredibly needed. But I have to say, sometimes patients look at me cross-eyed when I'm like, all right, I want you to go to a pelvic physical therapist. And they're like, what?
Yes.
So what is it that pelvic physical therapists do?
We help to manage all different types of pelvic floor issues related to both the pelvic floor and the abdomen and the hip, because all of those regions are closely aligned. So we help treat all genders, all backgrounds, all ages, primarily when it comes to women: urinary incontinence, pelvic organ prolapse, constipation, pelvic pain, issues with sex, so pain with sex or difficulty achieving orgasm, and then any lingering low back and pelvic pain that they may have from an injury or from pregnancy and childbirth. We basically cover the whole region, and we look at the person as a whole, and we identify their goals and help them get there.
And that the pain with sex topic is one that is very, it's a very sensitive topic. And I find sometimes women in particular will just kind of grin and bear it and just like blow it off as like, this is just a normal part of aging, or this is just a normal part of being a woman. What have you seen over the years?
Yeah, I have seen either that they are experiencing primary vaginismus, and that is where they are experiencing pain or restriction of the muscles to where penetration is not possible, either with a tampon, a speculum, or with intercourse. And they kind of move through this very frustrating paradigm of life where they're experiencing shame, they're experiencing pain and discomfort, and it's disruptive to their relationships. And generally, that is where the impetus is to come and seek help. And then there's also the secondary vaginismus, which is where they were at one time available to receive penetration without pain. And then something changes, whether it's a medical diagnosis or an emotional event or a traumatic event, and sex then becomes painful. And a lot of the primary drivers can be hormonally driven. Low states of estrogen are going to leave the walls of the vagina a little bit thinner and drier and less flexible and less receptive. And that can create a painful experience, which can then cycle into the pelvic floor muscles, which are muscles just like everywhere else, creating a guarding reflex where they anticipate pain with intercourse the next time, and they contract to protect you because it's a very deep-rooted guarding reflex, kind of like when people are stressed and they elevate their shoulders into their ears and they develop a headache. That can happen in the pelvic floor, or jaw gripping, jaw clenching. A lot of those people do also grip in through the pelvic floor, and then it becomes this awful cycle. Or they may experience something like a slip and fall on the ice, and they injure their tailbone and they injure their pelvic floor. And then they are experiencing pain with a deeper penetration. So the muscles are muscles just like everywhere else. We want them to be flexible and strong. So we want mobility and strength and stability. But there is a case where they become too tight or too strong, either from guarding or from different behavioral patterns. And when they are receiving penetration, they're getting a tender point or a trigger point hit. And that would be the same as if you had a knot in your neck or your shoulder and you pressed on it, and it's exquisitely painful. It kind of zings up and over your head and it feels very sore. It can feel that way with deeper penetration. But the good news is that the muscles can be retrained. There are techniques that we use that are very gentle to help restore that mobility, and then some coaching on some different positions to try and how to approach it more gently so that they can go on to have sex without pain.
And, I've heard from patients too that they're very like nervous because they're already having pain. And then I'm trying to send them to a pelvic physical therapist. And they're like, wait a minute, what are they going to do to me? So if you can
Yes.
explain like what happens when you come to a pelvic physical therapist.
Absolutely. The first question that a lot of people have is, are they going to make me do like push-ups or what? What is happening here? So pelvic floor physical therapy is a very highly specialized division of physical therapy where we have a lot of training in how to address these types of issues. So when you first come in, we are going to spend a lot of time first just talking with you about what the current problems are, what brought you in, what your symptoms are, and then also a lot about your medical history. So as I described, we treat a lot of different things because all of those organs are sitting right over the pelvic floor. So the pelvic floor holds the bowel, the bladder, and the vaginal canal and uterus. So if you come in for pain with sex, we are still going to ask you questions about your urinary habits and about your bowel movements and about your workflow and how much time you're spending doing different activities, because all of those impact the pelvic floor. So we spend a lot of time really just getting to know you, getting to know what your goals are. And then we do a really thorough evaluation. And all of the things that we need to evaluate may take place on the first day, and it may be that we get to it on a subsequent visit, because we're looking at your posture, we're looking at how your spine is moving and how your hips move and your hip strength. And then we are interested in assessing the coordination, the strength, and the flexibility of the pelvic floor itself. But in our history, a person that has a history of trauma or abuse, they may not be ready, or they may not be medically ready on that first day to have an internal vaginal assessment, or they may be in so much pain that it's just not going to be possible. And we have a lot of other ways of going about getting a sense of what's happening so that we can be working with you to get you to that point. The reason we do the internal assessment is to be able to determine if there are tender points and restrictions in the deeper aspects of that pelvic floor. But we can also observe. So we can ask you to do something like a contraction of the pelvic floor, and we watch to see, do your muscles know how to do that? And then on the other side of that, if we ask you to relax and bear down gently, do your muscles know how to do that? So it's a coordination piece, kind of like riding a bicycle, that can sometimes be lost, especially if someone's experienced pain. So we are interested in all of those different aspects, and then we're going to create your individual treatment plan based off of what we see.
You know, it's funny because having treated pelvic pain for years, it was surprising when 2 times in my life I actually went through it. But like I was lucky enough to know, like, okay, this is something that's going on and I can get help. The first one was after I was in a car accident, and the pelvis was fine, but I had herniated some discs in my low back. And it was so interesting. I remember like going to the regular physical therapist, and even myself knowing this, I was embarrassed because I wanted to be like, oh my God, I'm having pain on like the right side of my vagina, you know,
Yes.
from a back injury. So,
Yes, those nerve roots come out of the spine and they go down into the pelvic floor. So those two structures are very dependent on each other. And when they're working together, we can move and do all the things that we want to do. And when there's an injury to one, it can certainly affect its teammate.
and then the other time was I had had a hysterectomy. And I think just the trauma of surgery, like you said, the muscles will just go, we're going to try to protect you. We don't know what's happening. And I was like, really? Come on.
To add insult to injury.
Yeah.
Yes.
Yeah. Yeah. What do you see as the most common, or and I'm sure there's so many different things, but do you see a common kind of theme in what tends to cause pelvic pain or pain with intercourse?
Yeah, I would say two of the most common drivers, the number one driver I would say is stress and that guarding response. And most people, I would say almost all, unless they are a provider that has knowledge of the pelvic floor, are very surprised to know that they have that clenching pattern because it's happening involuntarily. They're not doing it on purpose. It's just this reflexive guarding associated with chronic stress, which is part of our lifestyle now, or after a very traumatic event. And so it may just be that it kind of crept up on them and now they have this pain and they're not really certain what caused it. There was no slip and fall or anything like that. So I would say that's the number one thing that brings people in. Number two would be an injury or a surgery to the area. So that would include a episiotomy, a C-section, or a tear during childbirth, or post-hysterectomy, or a gynecological procedure to where there's disruption, scar tissue, and injury.
What are the different kind of like as treatment modalities that can be done for these conditions?
So typically part of a comprehensive plan is we would do some manual therapy. It's again, very gentle. If you've been to physical therapy for your shoulder or for your back, this is very different. This is not a no pain, no gain. We're not pushing you into some stretch and making you feel pain in service of reaching some goal. That's not this kind of therapy. So with our manual techniques, we're doing very gentle myofascial release, showing you how to relieve scar tissue if you had the episiotomy or the tear or the C-section. We would be giving you some exercises to help rebuild the coordination of the muscles to where your brain gives a command and your pelvic floor knows exactly what to do. So for example, if you're having a bowel movement, it knows how to drop and relax. Or if you're going to be having intercourse, it knows to relax to allow that. Or if you're going to cough and sneeze, it knows to contract in order to protect from leaking urine. So you would receive some exercises based off of what your needs are. And then there may be tools involved too, which at Intimate Rose are something that we very much seek to empower people to be able to manage a lot of these symptoms on their own, either during the rehabilitation process as a means of moving through the process and reaching their goals quicker, or after discharge or independently, so that they can continue to maintain self-care and be experiencing pain-free, all the things, intercourse, bowel movements. So with painful sex, some of those tools might be dilators, which are a series of tools, devices that are cylinder-like, and they start as small as my pinky. And then throughout a set of 8, the next one would be a little bit longer and a little bit wider. And the goal of those is to help retrain the tissue in the vagina and the coordination of the pelvic floor muscles to drop and relax in service of penetration. So for people that are not able to tolerate their partner, they may be starting with a very small size dilator and gently and progressively working through the system so that they can train to reach the size of their partner. And after menopause, especially when that tissue does change and there's less estrogen and there's less flexibility, those dilators can be used to gently mobilize. It's not like a strain stretch like you would stretch your hamstrings. It's just a gentle mobilization, which allows you to gently and progressively gain that flexibility. And then a wand is a pelvic tool that it kind of looks like a question mark, but it's intended to get in and allow someone to do gentle myofascial release, similar to what we would do in clinic, to help restore that mobility and reduce those tender points throughout the pelvic floor.
We're talking a lot of times about like people who already have pelvic pain. Are there anything that we can do to kind of prevent ourselves from developing those symptoms to begin with?
Yes. So having good variety in your movement. So a lot of jobs these days involve sitting at a computer, and don't involve a lot of opportunity for maintaining good strength of the abdominals and the gluteal muscles and different varieties of movement. So having an exercise program in place, even if it's just 30 minutes 4 or 5 times a week, that allows you to be moving your hips and your spine in a lot of different ways, whether it's hiking on uneven terrain or doing some Pilates or yoga or lifting weights so that you're strengthening, so that you have good stability, and the pelvic floor muscles back up to those hip muscles. So they really need the hip muscles to be doing their job. Birth prep. So when you're preparing for birth, doing some stretching of the perineal body, which is that tissue right outside of the vagina, between the vagina and the opening of the rectum or the anus, that tends to either get accidentally torn or receive the episiotomy. So pregnant women can be doing some gentle stretching and mobilization, either with their hand or with the wand, in service of better playability during that childbirth. And then also taking steps and reporting it to your physician right away when you start to notice any change in your bowel, bladder, or sexual function, so that you can get it resolved very quickly so it doesn't taper out over the years. I think a lot of women, especially, they may have one painful episode of intercourse and they think, well, that was funny, that'll go away. And then it keeps happening, and that cycle becomes very deeply embedded in both their pelvic floor muscle coordination system and in their brain. And that can be a lot harder to unravel and to rehabilitate if it's been in place for a very long time. Not impossible. It's never too late, but the quicker that we can get that under control and re-coordinated, the better.
I was going to ask you, what about, I hear this question a lot. People are worried about doing Kegels. So yeah. I know a lot of times we're like, do your Kegels, do your Kegels, do your Kegels, but there are times when it might not be. So, when we're talking about pelvic pain in Kegels, what is your opinion on that?
Yes, it's really interesting. Kegels have all of a sudden gotten a lot of really bad PR, which is really unfortunate because it is one type of exercise of many that are very appropriate for some diagnoses and not appropriate for others. So we don't want to throw out all the good with the bad. And it's just looking at the appropriateness of it. So Kegels are a contraction of the pelvic floor muscles, and our body naturally does it, hopefully, when we have good coordination in place, when we sneeze or cough, so that we don't leak urine. And it is an exercise that is done to help rebuild that coordination pattern and strength and endurance in pelvic floor muscles that have become very weak. So that would be a great use for them. There's a lot of research behind it. They are not like a nonsense activity. But in people that have pain, oftentimes the muscles are in a tightened position, or there is tender points, or they have an over gripping or guarding response. And doing Kegels on top of that is going to further worsen that muscle tension. And so for that person, we are interested in doing the opposite. We are interested in retraining how to relax, almost like a fist that's been in a knot. And you ask somebody to squeeze harder. Well, there's not really much good in squeezing harder. We want to open that fist and make it so that it has good flexibility. So that is often what we are doing with people in pain. So that is just looking at the appropriateness of that one exercise. There's still really great tools for certain indications.
And I'm gonna throw you a curve one here, but you got this because you know all this stuff. But so I'm gonna circle back to the exercise because I'm thinking about this exercise thing again and how exercise affects our pelvic floor. Like, are there exercises in general that we should be doing that are better for the pelvic floor versus ones that we should be avoiding?
It is specific to the diagnosis. In general, going back to the hips, where the pelvic floor and the hip muscles basically share a tent wall. So if you picture two neighbors that share a tent wall, and somebody starts not holding up the slack on the tent wall, and you get collapse of the tent wall, that happens between the pelvic floor and the hip. So generally speaking, maintaining good hip mobility and strength is a great service to the pelvic floor. So some exercises along those lines might be bridges and clamshells and standing, doing little kicks to the side, because you're getting good activation of the side muscles. And those are muscles that don't often have an opportunity to do fun things based on our sit and walk forward lifestyle that a lot of us are leading. So, all of those are going to introduce blood flow to the region and mobility and overall stability. So those are some that are pretty crowd pleasing to all the diagnoses. But when it comes to the pelvic floor itself, we would be basing it on what the actual diagnosis is.
That is great. Now, and I never really thought about. I'm thinking about my own exercise right now. I'm like, I don't think I'm doing a lot of hip mobility stuff. So I'm gonna make sure I incorporate some of that into my exercise. So,
Yes.
is there anything that I didn't ask you about pelvic pain or pelvic physical therapy that you want us to know about?
Well, I would just highlight that it's a team approach between all of the different providers, gynecologists and pelvic floor physical therapists. And then additionally, if there are other bladder diagnoses, the urologist may be involved. And that from the gynecology side, there's so much that you can offer in terms of vaginal estrogen and medical management that are going to complement our work together. So, it's looking at it from, I always liken it to a canoe, where you've got to have a great gynecologist in your canoe and a great pelvic floor PT, and we're all going to help paddle you in the direction of your goal. So it's not, that we're trying to be doing it in a vacuum. It's the vaginal health is important. The pelvic floor is important. Our movement patterns are important. And sometimes it does take a bigger team. And so we're always looking to see, is there additional workup? Is there additional imaging that may be helpful to getting this person to where they need to go faster? So we're always so thankful for great gynecologists. And that's what makes a good team.
It's something I've thought about too is like, you go to the gynecologist every year because everyone's like, oh, get your pap smear. But I really think we should be seeing a pelvic physical therapist every year. I don't know why that hasn't been like included as, some sort of recommendation or even a check-in, maybe even every couple of years. Because I think in France, they send all their postpartum women immediately go through pelvic physical therapy, and they have such lower rates of pelvic floor issues than we do in the United States. And I'm like, whoa, why don't like if you have knee or hip surgery, some sort of orthopedic surgery, they automatically throw you into pelvic physical therapy. I don't understand why we're not as moms getting thrown into like the moment you give a birth, like, okay, now let's go rehab your pelvic floor.
You hit the nail on the head. In France, every woman gets 12 visits of what they call perineal re-education with a pelvic physio. And we are working on it here in the United States. We are working on advocacy, in legislation with our payers, the insurance payers, and ensuring that they understand what we're doing and how our work is going to prevent greater cost long term, because it does impact all of those things. It impacts their ability to go back to work. It impacts if they are purchasing lots and lots of pads and other types of things that add up in their overall costs as a person. So we're working on it.
So I'm gonna anybody who's watching this, I'm gonna say you guys should start like requesting this from your doctors, your physical therapists, and your insurance companies, and be like, this is what I need to get better. Because I have seen, I think the insurance companies in general have gotten much better at covering things like pelvic physical therapy. But I have to say, over the years, when I've seen things that insurance companies haven't covered, I have seen patients shock me where they have called and bugged their insurance company enough that I think the insurance companies are like, okay, fine, just go ahead and do it and we'll pay for it. So.
Good for them. That makes me so proud of them advocating for themselves, because we get on the phone with the payer too. But it's very powerful coming from the person who's paying that monthly payment to the insurance company.
I say you keep bugging them, and I've seen stranger things happen. So definitely.
I love it.
Awesome. Where can people find out more information about you?
The best place to find out more is on Instagram at Intimate Rose and at A Olsen DPT. I offer a lot of educational videos there. And then on our website, intimaterose.com, I have hundreds of different free resources, videos, guides on all different pelvic health topics. And then if people are interested in some of the tools, they can find complete guides there of how to use them. We can help connect people with a pelvic PT in their area based on their zip code if they identify that they have a need. So they can find us there. And then we are on Facebook as well. We have a private Facebook group that is a safe place for people to share stories. It's the Intimate Rose private group for people that are just needing support as they're going through the rehabilitation process. And then we are on the lighter side of social media on TikTok now as well.
That is fun. I'm gonna go find your TikTok because that's a fun one.
You always learn more about a person when you see.
Yes. Oh my goodness. My TikTok is definitely where I get a little goofy. So
yes. We still keep ours very classy, but it is a little bit more lighthearted for sure.
Oh my goodness. Everybody, make sure you go check that out and stick around. We got more great episodes coming up. Thank you so much, Amanda, for being with us.